Hi, welcome back. Today we'll be talking about upper and lower motor neuron lesions. So firstly, the first thing I want to tell you, we have a muscle. And inside muscles, we have extrafugal fibers. And these extrafugal fibers are usually what causes the muscle to contract. Now there's other fibers as well that here are highlighted in orange, and these are muscle spindles. And inside the muscle spindles, there's intrafugal fibers. Now, one thing I want you to know that these do not get involved when it comes to contraction. Only the extrafugal do. Now, the way these are innervated, so you have the spinal cord, which I'm going to draw here, and you have the ventral side, which is known as the motor side, and the dorsal side, which is the sensory side. So, because motor is movement, so the ventral side is the one that directly links to the muscles, and alpha motor neurons innervate the extrafugal fibers directly. And in order to innervate the muscle spindle, we have gamma motor neurons. Now, bearing in mind, these are only 30% of the full story, and both of these together are known as the lower motor neurons. Now, these do get signals from something that's higher up, so these are known as upper motor neurons. The first one I want to talk about is the one that comes straight from the cerebral cortex, and this one's known as the corticospinal tract fibers, and these are also known as descending fibers, and these come directly from the cerebral cortex and innervate into the dorsal side, which is the sensory, and they either communicate directly with the alpha motor neurons or they use an interneuron. We also get signals from the brainstem via the tectospinal, so from the tectospinal or the vestibulospinal tracts, and these are also known as descending. So you have the brainstem and the cerebral cortex sending sensory information to the spinal cord, the dorsal side, which then communicates with the ventral side, which then communicates with the muscle. Now the ones up and above, the corticospinal and the tectospinal and the vestibulospinal, are known as upper motor neurons, whereas the ones at the bottom are lower motor neurons. Now, one thing I want you to realise is that here, you need to know that the upper motor neurons almost are inhibitory. So one way of understanding this would be to think of it like the upper motor neurons is a teacher. So if the upper motor neuron is present, all the students meaning the lower motor neurons, they're all intact and they're all listening to the upper motor neuron. Now, as soon as you get rid of the upper motor neuron, like say there's a lesion, then that will cause the lower motor neuron to almost misbehave. The class becomes rowdy, more misbehaving, and doesn't function the way it needs to. So now let's focus on, let's compare upper motor neuron and lower motor neuron lesions. So for upper motor neuron, so this, you need to understand the upper motor neurons, because it's a tract, it will innervate a group of muscles, whereas when we're looking at lower motor neurons, we're usually talking about one set of muscles. So now let's look at the tone. Tone basically means the resistance offered by a muscle during passive stretch or elongation. So if we're passively moving or elongating a muscle, it just shows how much resistance we will feel. So now, like I said earlier, if you get rid of a lesion in the upper motor neuron, so if you have a lesion in the upper motor neuron, this is going to cause chaos. So the more chaos in the lower motor neurons, which is going to cause our lower motor neurons to almost keep working and cause hypertonia. Whereas if we have a lower motor neuron lesion, we can't get to that reflex arc between the muscle and the ventral horn, causing hypotonia. Now, because earlier I said tone is increased, so therefore the more tone you have, the more the muscle, let's say, moves, the weaker it becomes. So there is less wasting in upper motor neurons because there is still a reflex arc that's happening in the lower motor neurons. However, if the lower motor neuron is cut, there is completely no reflex arc, and then because you have a hypotonia, the muscle is not being used, and therefore there is muscle atrophy. Next, let's talk about fasciculation. So fasciculation is just like abnormal twitching of the muscle without any stimulus. So there is, in an upper motor neuron, there is no fasciculations. However, in a lower motor neuron, there is fasciculations, as the reflex arc is still trying to, make its way and keep going. And also there is weakness in both upper motor neuron and lower motor neurons. The limbs do not work like they used to. And the reflexes in upper motor neuron, there is hyperreflexia. Now, with regards to the Babinski sign, in upper motor neurons, it is a positive, and whereas in the lower motor neurons, it's negative, so it's said to be a flexor. And basically, the flexor means that it's not elicited. And when it comes to paralysis, we say that the upper motor neuron is spastic, whereas lower motor neuron is flaccid. And some examples of upper motor neuron is multiple sclerosis or a stroke that includes ischemic stroke or a hemorrhagic. In lower motor neurons, we have Guillain-Barré syndrome, or we have poliomyelitis. But just one final note. Situations where we can get a positive Babinski without there actually being a pathology, one of it is in children. So in children less than 1 year of age, the corticospinal tract is not fully developed, so therefore you will get a positive regardless of whether they have a pathology. And some stages of deep sleep have also elicited a positive Babinski without a pathology as well. Thank you.